Um, okay, so chronic obstructive lung diseases, usually they include COPD, asthma, presenter, and bronchitis. Okay, enter. Okay, so COPD consists of two entities, chronic bronchitis and emphysema. Enter. Okay. Okay. So COPD is mostly an irreversible process, and what both chronic bronchitis and emphysema have in common is that they are caused due to predominantly smoking. Whereas asthma usually has reversible bronchospasm, but later on it becomes irreversible later on, and it is usually caused by allergens and infections. Next. Okay, so this is a picture from Robbins where it says that usually there is an overlap. So emphysema overlaps with chronic bronchitis, which can overlap with asthma. While emphysema and chronic bronchitis, as you can see there, is caused due to smoking. Asthma is caused due to bronchial hyperresponsiveness due to allergens and infections. Next. Okay. So what is COPD? So this is a long definition that is there in Robbins. It is a common preventable and treatable disease that is characterized by persistent respiratory symptoms and airflow limitations that is due to airway and or alveolar abnormalities caused by exposure to noxious particles or gases. So this is really cumbersome to remember. So we will break it down. So when you split it into terms, first word is common. So can you press enter? Yeah, so it is common. It's so common that it's a fourth leading cause of death in the world. So common you can remember. Next. Okay, so it is preventable. How is it preventable? Because it is caused due to exposure to noxious particles or gases. So if you prevent the exposure to noxious particles or gases, you can prevent the disease. Next. Okay, so what are these noxious particles and gases? They are smoking and environmental pollutants. Next. Okay, so go back. Yeah, so it is treatable. So when you see a case of COPD, you will be able to manage it, but nevertheless, there will be persistent respiratory symptoms. So you will treat the patient, but they will come back to you with persistent respiratory symptoms. The next term is airflow limitation. So that is where the O part of COPD comes in. So it is obstructive disease. That's where there is airflow limitation, and there is problem in the airway and or alveoli. Next. Okay. So the current hypothesis for the pathogenesis of COPD is it is caused by abnormal response to the inhalation of toxic particles and gases. So we already know that COPD is caused by inhalation of toxic particles and gases. But are all people who inhale toxic particles or gases get COPD? No, they don't. So there is an abnormal response to it in certain people. So when you look at the lung pathology in smokers, there is a low-grade inflammation that you see, okay? But in a lot of smokers, this does not cause any defects, so they go on just fine. But in a susceptible minority, around 35 to 50% of people, there is an amplified response to this. So that causes COPD. And in these susceptible minority, the changes persist long after smoking cessation. And there are hypotheses that this is linked to the tissue remodeling process. So first they inhale the toxic particle gases, there is an inflammatory response, there is probably an exaggerated inflammatory response in these people, and then once there is inflammation, there is tissue remodeling. And that tissue remodeling also is abnormal in these people. Next slide. Okay, so let's talk about expedition that happened. So this was the 41st Japanese expedition to the South Pole. These people went via sea from Japan to Antarctica, and they were there for a couple of months, I think for a duration of 6 months or so, and then they came back. So as they traveled from Japan to the South Pole via sea, they, can you go to the next slide, please? Yeah. So what they did is they measured the particulate materials in the air. So as you can see in the graph, during the outward voyage, in Japan, there was maximum particulate material in the air. But during the outward voyage to Antarctica, it went down and down. And then in Antarctica, the particulate material in the air was the least. And then it increased again during the homeward voyage. And in Japan, again, it was the maximum. Okay, so along with this, what they did was whoever was there as part of the expedition, they measured certain things for them. They did pulmonary function tests for them. They measured the circulating levels of segmented polymorphic PMNs, neutrophils. So segmented neutrophils, band neutrophils, monocytes, and cytokines. Okay, and what they found was as the particulate material in the air decreased as they went towards Antarctica, there was a decrease in the level of neutrophils, there was a decrease in the level of monocytes, there was a decrease in the level of cytokines. And this remained low as long as they were in Antarctica. And as they came back to Japan, all these levels continued to increase and it was a maximum in Japan. So what they found was there is a response to the particulate material in the air, and that response is inflammation. Okay, and the interesting thing that they found was in smokers, obviously you would expect that there would be a higher level of all these things because irrespective of the airway pollution, the smokers continue to they smoke, so they have particulate material in their respiratory system. So you would expect their baseline levels to be higher, and they were higher as long as they were in Japan. But when they went to Antarctica, the difference between the smokers and non-smokers disappeared. So, next slide. Okay. A similar study was done on the Southeast Asian haze. So what happens here is in Southeast Asian countries, they burn crops basically. So once they finish cultivating the land, to clear the land, they burn all their crops. So it is easier for them to clear the land that way. It is illegal, but they still do it. So this results in complete haze in all the Southeast Asian countries from October to December. And so what they did was they measured the similar parameters in the previous study in Singapore military recruits during the Southeast Asian haze. And what they found was similar. Before the haze, they had low levels of neutrophils, band cells, and cytokines. And as the haze progressed, these levels also increased. And as the haze disappeared around December, the levels came back to normal. So what this says is the environmental effect is much as important probably as smoking is. Next slide. Okay, so this is what I said. Small changes in atmospheric pollution, which increases pro-inflammatory cytokines and release into the blood. And this increases the production of acute phase reactants in the liver, as well as it also stimulates the bone marrow to produce more leukocytes and release them into the blood. Next slide. Okay, so coming to emphysema. Emphysema is defined by irreversible enlargement of the air spaces distal to the terminal bronchiole accompanied by destruction of their walls. Next. Okay, so first we need to know is it is irreversible, and that's obvious because we know that COPD by itself, emphysema or chronic bronchitis, is irreversible. Next. Okay. So there is enlargement of air spaces. Next. Okay, so these air spaces are distal to the terminal bronchiole. Next. Okay, so what is the terminal bronchiole? So this is airway. So you have a trachea, bronchiole, terminal bronchioles. And so what is distal to the terminal bronchioles are your respiratory bronchioles. I'm not able to see the screen.
Ma'am, are you able to see now? Isn't it visible, ma'am?
Okay, yeah, I'm able to see. Yeah. Hello? Yeah.
Yes, ma'am.
So what is distal to your terminal bronchioles? So your respiratory bronchioles, your alveolar ducts, and your alveolar sac. Next. Okay. So why is there enlargement of the air spaces? It's because there is destruction of their walls. And in certain definitions, they say that it is accompanied by minimal fibrosis. But I think this is very difficult to determine because usually there is an overlap between chronic bronchitis and emphysema. So whatever fibrosis that is there due to chronic bronchitis, you will usually see in cases with emphysema. Next. Next. Have you changed the... Okay. So what are the types of emphysema? You can, there's centriacinar, there's panacinar, paraseptal, and irregular. Out of these, the most common ones you encounter are centriacinar and panacinar. Centriacinar is usually seen in smokers. So what happens in centriacinar is, so this is a part, in the picture, that is a part that is dilated, that is enlarging in an emphysema. Respiratory bronchiole, alveolar duct, and alveolus. In centriacinar type of emphysema, it is the respiratory bronchiole that enlarges. In the panacinar type is usually seen in alpha-1 antitrypsin deficiency. In panacinar type of emphysema, initially the alveolar duct and the alveolus enlarges, but eventually what happens is the entire respiratory unit ends up enlarging. Paraseptal and irregular types of emphysema are very rare. In paraseptal type of emphysema, only the terminal part, the alveolus and the alveolar duct enlarges, and this usually happens close to the pleura, and they result in formation of multiple blebs and bullae. So when these rupture, the patient can develop spontaneous pneumothorax. In irregular type of emphysema, there is usually scarring associated with enlargement of the air spaces, and usually it is very small and clinically insignificant. So this is something that you usually don't encounter. Next slide. Next slide. Okay, so this is a picture. Yeah. So on your left is what you see is the centriacinar type of emphysema. So you can see the enlarged air spaces in between, but it is surrounded by relatively normal air spaces. But on your right, it is your panacinar. So almost all the air spaces are uniformly enlarged here. Next. Okay. In the centriacinar type of emphysema, your upper lobe is more affected than your lower lobe. Whereas in your panacinar, it is the other way around. Your lower lobe of your lung is more affected than your upper lobe. Next slide. Next slide. Okay. So coming to pathogenesis of emphysema. Yeah, go back. Yeah, so most of the cases of emphysema that you encounter are seen in smokers and in alpha-1 antitrypsin deficiency. So there are very little other causes of emphysema. And the pathogenesis, it is due to toxic injury and inflammation. So when a person smokes or when there is increased air pollution, there will be injury to the epithelial lining of the airway, and this will cause inflammation. Then there is something called a protease-antiprotease imbalance. In protease-antiprotease, I will come back to that later. In oxidative stress and free radical injury, so when a person who smokes takes in a lot of particulate matter. So this particulate matter as well as the inflammation that comes in, all of this ends up producing a lot of free radical, which causes injury. This was confirmed by this NRF2 transcription factor that was done in mice. So this NRF2 is a transcription factor that helps in signaling. So when there is a lot of oxygen stress to the cell, this NRF2 factor gets active and it senses that oxygen stress and it helps to protect it by creating a lot by producing antioxidants. So in mice where this NRF2 factor was inactive, they were more likely to develop emphysematous changes. Superadded to all these changes, the patient can also have infections which will further exacerbate the problems. Next slide. Okay. So this is something that I have blatantly stolen from YouTube. So what happens here is, so the patient smokes. The smoke by itself can produce reactive oxygen species. Okay, that we know. Next, the smoke goes in, and what you see inside the alveolar here is an alveolar macrophage. So the smoke triggers, or it activates the alveolar macrophage. And what does the alveolar macrophage do? It produces interleukins, it produces cytokines and chemokines basically. So it produces interleukin 6, interleukin 8, interleukin 1, TNF alpha, all of those. So what these is they are cytokines. So basically they will recruit neutrophils. So when neutrophils come to the spot, what they do is they produce proteases. Mainly they produce elastase. So what elastase does is, it destroys elastin basically. That's what the name indicates. So all your airways have elastin. So this black thing that you see on top, that is elastin fibers. So the elastase will destroy the elastin. So normally what happens in your body is there are some things called anti-proteases. Okay, so these anti-proteases will act against these proteases and protect our airspaces from getting destroyed. Okay, in a normal individual, it will help to protect the airspaces from elastase. Apart from that, there are metalloproteinases which are produced by the alveolar macrophage, which further helps to destroy all the airspaces. Next step. Okay. So the elastic fibers are already destroyed by elastase. Okay, and then what happens is, apart from neutrophils, the cytokines also recruit all your cells of your adaptive immunity. So your T lymphocytes are getting recruited, and they cause further damage. Okay, so whenever there is damage to the airspace, what happens? Like in your inflammation chapter, you would have heard that once there is inflammation, there is healing, and this healing takes place by fibrosis. So collagen gets deposited, and that causes fibrosis around the airspaces. Next. Okay. So let's talk about alpha-1 antitrypsin deficiency briefly. So alpha-1 antitrypsin, I told you earlier, right? There are anti-proteases that are there in your body. So alpha-1 antitrypsin is an anti-protease. It is normally present in serum, tissue fluids, and macrophages. And it is a major inhibitor of proteases, especially elastase. So in a normal individual who has a normal level of alpha-1 antitrypsin, it will work pretty well and it will protect your airspaces. But if a normal individual smokes, or if he's exposed to a lot of air pollution, what happens is this alpha-1 antitrypsin gets overwhelmed. There's so much proteases that are being produced that the alpha-1 antitrypsin is not able to function enough. It gets overwhelmed. So your airspaces gets destroyed. Okay, but there are certain individuals who have a polymorphism in alpha-1 antitrypsin. That is a homozygous for the Z allele. So this results in very low serum levels of alpha-1 antitrypsin. So those individuals are even more susceptible to having their airspaces destroyed by proteases. Okay, so those individuals are the ones that get pan-acinar emphysema. So all their airspaces get destroyed a lot, and this happens much earlier and with greater severity, especially if they are smokers. So if you add the deficiency along with smokers, then the situation is really bad, basically. Next. Okay, so can someone tell me what this is? What organ this is? Hello? Hello? Can someone tell me what organ this is? Anirudh. Yeah.
No, I'm not pancreas. I'm not really sure. It's quite confusing.
Shweta says it's lung alveoli because I think we're talking about COPD. No, Shweta, you're extremely brilliant, but no, that's not.
Pancreas, ma'am.
Okay, no. So this is a liver. So you can see the hepatocytes. These are cords of hepatocytes. Yeah. I'm not, you won't be able to see my mouse move. Anyway, these are cords of hepatocytes. And on the top right corner, you can see a bile duct. Move further to your 11 o'clock position. No, top right, top right. Okay, someone will show. Yeah, that one. That is a portal tract, and the corner of that is a bile duct. So this is a liver. So in the context of what we're talking, what is happening to the liver? Okay, so within the hepatocytes, you can see these round globules. Can you see that? No, below. Yeah, within them. Within the cytoplasm of the liver, you can see these round red eosinophilic. Yeah, those things. Okay, so these globules are highlighted on the right. So on your right is a PSD stain. So periodic acid shift diastase. So these globules are getting highlighted there. So this is a case of alpha-1 antitrypsin deficiency. So basically what happens is alpha-1 antitrypsin is produced by the liver, okay, and it acts on the lung. Okay, so when there is this, when there are abnormal forms of alpha-1, when there is a polymorphism in the allele, what happens is it results in the production of abnormal forms of the protein. So not only is the protein not functional, these abnormal forms of the protein get misfolded, and it's not able to send it out of the body basically. So it gets accumulated within the hepatocytes as these globules. So in alpha-1 antitrypsin deficiency, there will be dysfunction of the organ in which the alpha-1 antitrypsin is produced, which is the liver, as well as the organ in which the alpha-1 antitrypsin acts, which is the lung. Next slide. Okay, so we know that there is destruction of the airspaces in emphysema, as well as destruction of the elastin fibers. So elastin fibers is necessary for elastic recoil of the airspaces. So this is what happens in a normal individual. So at the end of inspiration, what happens is, so the atmospheric pressure is always 0. Okay, and the elastic recoil of the lung pulls inward away from the chest wall. So within the pleural space, the pressure is -12. Okay, now there is a transmural pressure. So transmural pressure is a pressure in between that is there with that it's a difference of the pressure between the airspace and the pleura. So this difference is 0 minus -12. So it is +12. So that means that the airway remains open. Next slide. Okay. So at the end of expiration, what happens is the atmospheric pressure still remains 0, but within the airspace, the pressure increases. So there is a gradient that is established. So at the bottom, towards the distal portion of the airspaces, it is 12, and in the atmosphere, it is 0. So there is a gradient that's there. But within the pleura, the pressure is 0 because expiration is a passive process. So there won't be any pressure exerted there. So when you calculate the transmural pressure in this case, the pressure is still in minus out. So 12 minus 0, which is still 12, which means the airway remains open. Next slide. Okay. Now when a person does forced expiration, what happens? It is no longer a passive process, right? So there is some pressure, the intrapleural pressure is increased. So let's say it is 16, okay? And the pressure gradient, it changes a bit. So it is 0 to 28 here, okay? But because there is intrapleural pressure is 16, can you see this point where there is 14 within the alveolus, okay? At that point, the pressure between the intrapleural space and the airspace is 16 minus 14. It is 14 minus 16. So it is negative. So what happens there is compression of the airway, right? So this is called dynamic compression of the airway. So what happens is the air is not able to get out after that point, right? So no matter how much you try to force it out, the more you force it, the airway will collapse even more. So you'll not be able to expire the air after that point. So this happens in individuals during forced expiration. Next slide. Next slide. Go down. Okay. So what happens in emphysema during forced expiration is there is no elastic recoil. So the intra-alveolar pressure remains less. Okay. So this gradient earlier in a normal lung, if you look at the bottom left corner, it is 7 to 28. But in emphysematous patient, it's only 5 to 20. So this is because of the loss of elastic recoil that is there in the lung. So if you look at the difference, it is 10 minus 16 here, it is 15 minus 16 here. So what this means is there is more collapse of the airway. In a normal lung, at only one point it was collapsing. But in emphysema, almost the entire airway is collapsing. And this is during forced expiration. In severe emphysema, it even becomes like during normal expiration also, there is collapse of the airway. And because the airway collapses, what happens is oxygen gets trapped in the distal air spaces. So no matter how much the person tries to force it out, it will remain trapped there. Next slide. Okay. So this is a gross of an emphysematous patient. You've already seen it. This is centriacinar and panacinar emphysema. Next. Okay, so this is an autopsy case of a patient who passed away due to emphysema, and you can see that there are numerous bullae that are there on the surface of the lung here. Yeah. Next slide. Okay, so this is a microscopy. Is everyone able to see it? Okay, I think you'll be able to see it. On the left is a normal lung. On the right is an emphysematous lung. So okay. So, okay, it's a good thing I put arrows here. So the red arrow on the right side, okay, yeah, that is pointing towards a blood vessel, okay. Can you see a blood vessel, a similar blood vessel on your left side in the normal lung? No, okay, that's also a blood vessel, but move further towards it. A large one is there, right? Yeah, that one, okay. So the difference between the left and your right is that in the right, there is a gap between the air spaces and the blood vessels. Can you see that? Yeah. So the air space is not completely adherent to your blood vessels. Okay. And then you can see all these dilated air spaces throughout. So you compare the size of the air space that's there on your left, on your right. Okay. On your left, it is regular and small. On your right, it is dilated and large. And the green arrows are pointing towards what is called as pores of Kohn. So normally, adjacent air spaces are adjacent alveoli joined together by something called a pores of Kohn. In emphysema, the pores of Kohn becomes so wide. So you can see the gaps right in between. The green arrows. What is the green arrow pointing at? It's pointing at a gap. So these are the gaps in between adjacent alveoli that become so large that it seems like the septa is like floating in air. Okay. Next slide. Okay. Coming to chronic bronchitis. Chronic bronchitis is defined clinically as persistent cough with sputum production for at least 3 months in at least 2 consecutive years in the absence of any other identifiable cause. So first thing you need to know is it is a clinical definition. So as a pathologist, we don't really do anything in the diagnosis of chronic bronchitis. And second thing is there is cough with sputum. So sputum production is the most important aspect of chronic bronchitis. So most of your symptoms of chronic bronchitis is due to the production of abundance of sputum. Okay, and then there is a duration. So the duration is 3 months and 2 years. And most importantly, you have to rule out any other identifiable cause. Next slide. Next slide. Okay. So like I said, sputum production is the most important part. So why is there sputum production? Because there is hypersecretion of mucus. So where does this mucus come from? So the mucus can come either from the goblet cells that are there in the lining of the respiratory epithelium, or they can come from the submucosal glands that are there in the trachea and bronchi. So both of these are increased during in chronic bronchitis. So there is enlargement of the submucosal glands, and there is increase in the goblet cells. Okay, and plus there is inflammation. So long-standing inflammation is there, which leads to fibrosis. Okay, so for this fibrosis involves usually the small airways, so the small bronchi and bronchioles, and it causes chronic airway obstruction. And like emphysema, chronic bronchitis also can get complicated by infections. Next slide. Okay, so this mucus hypersecretion is caused due to inflammatory mediators such as histamine and interleukin-13. So basically, they produce this because they want to protect the airways from tobacco smoke and other pollutants. But this protective mechanism becomes too much to handle, and it becomes like exaggerated. So that causes all these problems. Next slide. Okay, so this is there in your new Robbins. It wasn't there in your old one. So there is a dysfunction. So people have found that there is a dysfunction in the cystic fibrosis transmembrane conductance regulator. So this is what is, so if you remember from your general pack, this is the transporter that is defective in cystic fibrosis. So smoking in cystic fibrosis, there is an inherited defect in this, but smoking leads to an acquired CFTR dysfunction. So if you look at the picture, normally your chloride has to go out and your sodium comes in. As your sodium comes in, it draws in water from your airways. Okay, but when CFTR is dysfunctional, as in your right, okay, chloride doesn't go out. So chloride stays within the cell, and to compensate for the charge or to maintain the charge within the cell, there is more sodium that comes within the cell. As more sodium comes within the cell, more water comes within the cell. So this results in abnormal dehydrated mucus. So there is a lot of mucus production, and the mucus is dehydrated, so it doesn't really do the job that it's meant to do. So this exacerbates the severity of chronic bronchitis. So this is like a new development. There is an acquired CFTR dysfunction in smoking. Next slide. Okay, so these are a couple of pictures. On your left, you can see these small dots that you see. I'm not able to point out to anything here. Okay, so the thing on the picture on your left, okay, so you see a lining epithelium there. Yeah, good. So that is your bronchial, your respiratory epithelium, right? So beneath that, you see some small dots. No, to your left of that, to the left of that. Yeah, can you see some small dots? Those are your inflammatory cells. So there's chronic inflammation in chronic bronchitis. Okay. Coming to the picture to your right, what is B? B points to your submucosal glands. So you can see an increased amount of submucosal glands in chronic bronchitis. Next. Okay, so this is pretty self-explanatory. In normal donor lungs, you don't see that many goblet cells. Okay, in COPD, the picture to your right, you can see a lot of goblet cells. And this goblet cells in the picture below is highlighted by Alcian blue. So it becomes blue in color. Next slide. Okay, see some more pictures. B is a mucus plug, which is there within a bronchus. Okay, C is within the lumen, you can see inflammatory cells. Okay, D is thickening of the bronchus because of smooth muscle hyperplasia and fibrosis. So around the bronchus also you can see fibrosis that's there. Next slide. Okay, so this is Reed index. So what is Reed index is, if you look at the picture, okay, at point A, you see the epithelium, right? Point B is where your submucosal glands begin. Point C is where your submucosal gland ends. And point D is where there is cartilage. So all your bronchi have cartilage, right? Okay. So your Reed index is basically BC by AB. So it is the thickness of your submucosal glands divided by the distance between your epithelium and your cartilage. Okay, so when there is chronic bronchitis, as I told you, there will be hyperplasia of the submucosal glands. Okay, so obviously your BC distance will increase, right? So normally, in a normal patient, this read index is less than 0.4. But in a patient with chronic bronchitis, this BC distance increases. So obviously the read index will increase. Okay, so the read index will be more than 0.4 in a patient with chronic bronchitis. Next slide. Someone told something, Richard. Okay, you can please click view options. Okay, and I can annotate. Okay, so can you see my pointer now?
There's a pointer here, ma'am. I've clicked annotate.
No, he's asking me to do it. So can you see my pointer?
No, ma'am.
No. Menu, I can click on the arrow. Now can...
Yes, ma'am.
Yeah, okay, good. Okay, thank you, Sudarshan. Yeah, okay. So then the bronchial epithelium, not only will there be goblet cell hyperplasia, it can also exhibit squamous metaplasia. So where I accidentally put this pointer here, that is squamous metaplasia. So you saw the lining before, right? They were columnar epithelial cells. These are squamous, as you can see by the eosinophilic cytoplasm. Then there will be marked plugging by mucus, inflammation, and fibrosis. Sometimes the fibrosis can be so severe, yeah, like here, and it will cause obliteration of the bronchioles. So this is called bronchiolitis obliterans. Next slide. You will not be able to do it when I annotate.
So try changing a slide, ma'am, since you are taking control.
Am I taking control? I'm not. I'm not able to change the slide.
Yes, ma'am. Once.
Okay, you changed it. Okay. So the clinical features, earlier in your previous editions of Robbins, what they did was they described the clinical features of chronic bronchitis separately and the clinical features of emphysema separately. Okay, but here they have clubbed it together, basically because chronic bronchitis and emphysema are not actually distinct entities. Because in most patients, because both happens in smokers, both happens due to environmental pollution. Why would a person be purely emphysematic? Why would a patient be purely bronchitic? Why would he have purely chronic bronchitis? No, in most patients there is an overlap of symptoms. So that's why I think in the new edition of Robbins they have clubbed together both the clinical features. So when a patient comes to you, predominantly he will usually be a smoker, and when you ask for smoking history, usually there will be a smoking history of 40 pack years or greater. Enter. Can you press enter, please? Okay, so this is just an interesting fact. If a person who's 60 years old has smoked 1 pack per day starting at the age of 20, he would have inhaled smoke generated from approximately 290,000 cigarettes during the course of his lifetime, like between the ages of 20 to 60. So you can see how bad his lungs would be. Next slide. Okay, this is another interesting graph. Okay, so this one. Okay, this line is the FEV1. So FEV1 is the forced expiratory volume, right? At 1 minute. So FEV1 declines with aging. right? Normally itself it declines with aging, okay? But this is the FEV1 of a person who smokes and is susceptible to smoke. So it was important to notice here that it is never smoked or not susceptible to smoke. So there are people who can smoke but who are not susceptible to it, who can have a normal FEV1. But here is the person who has smoked and is susceptible to smoke. So his FEV1 decreases dramatically from the ages of 20, 25 to 75. Okay, so at this in this line you can see these two exit marks. Okay, so if he stopped smoking at the age of 50, his FEV1 is still declining, but it stops declining as dramatically as it does if he continues to smoke. At here, if he stops smoking at the age of 65, again his FEV1 does decrease, but not as dramatically as it does if he continues to smoke. So I think you can learn that it's never too late from this graph. Next slide. Okay. So most patients present with dyspnea on exertion and chronic cough is sputum production. Okay, and this will be increasing over time, and it will gradually increase over time. Apart from that, there will be numerous acute exacerbations. So the patient usually presents to you with acute exacerbations, but he will decline over time. Next slide. So what causes an acute exacerbation? He can get a lung infection, especially if it is a new strain of virus or bacteria is not been previously exposed to. It can be occupational or environmental inhalation challenge. If he suddenly moves to a more polluted city, then he can present with exacerbation. Or in many cases, the exacerbations are idiopathic. No one knows why there is an exacerbation, but he presents with an exacerbation. Next slide. Okay, so the most important diagnostic test is spirometry. So that is FEV1, that is forced expiratory volume at 1 second divided by forced vital capacity. So I think you know the difference between an obstructive and a restrictive lung disease. In an obstructive lung disease, FEV1 decreases and FVC. Okay, FEV1 decreases disproportional to your FVC. Okay, so your FEV1 decreases so much more than your FVC decreases. So the ratio becomes less than 0.7. But in a restrictive lung disease, FEV1 and FVC both decrease, but the decrease is proportional to each other. So here, FEV1 has decreased. FVC has also decreased, right? But it is proportional to each other. So the ratio remains pretty high. But here in obstructive pathology, FEV1 has decreased so much more than your FVC has. Okay, so your ratio decreases. And here the ratio will be less than 0.7. Next slide. Okay. And the symptoms often wax and wane. So some days the patient will be better than other days. So basically there will be exacerbations, there will be good days for the patient, but overall the severity of the disease will increase. Okay, and this will vary according to how much bronchitic change he has, how much emphysematic change he has. Next slide. Okay, so this is a common trope that is there. Everyone knows about pink puffers and blue bloaters. So pink puffers are what we call patients who are at the emphysematous end of the spectrum, and blue bloaters are what we call the patients who are the chronic bronchitic ends of the spectrum, right? But most patients are not neither pink puffers or nor blue bloaters. They have a combination of symptoms of both the symptoms. Next slide. Okay, can you press enter? Yeah, so let's talk about blue bloaters first. So this is usually a patient with chronic bronchitis. So this is a diagnosis of chronic bronchitis, which I've already told. So a patient with chronic bronchitis, they generally say, has persistent cough and productive sputum, because sputum production is the basis of chronic bronchitis. And there is hypercapnia and hypoxemia. Why is there hypercapnia and hypoxemia? Because there is mucus plugging and there is fibrosis. So obviously your air is not allowed to go into your alveolar spaces. So in that case, there will be decreased oxygen and increased carbon dioxide. So because of this, the patient has mild cyanosis because he's not getting oxygenated well enough. Okay. So we already dealt with the cyanotic part of this. Then the patient is overweight. Why is he overweight? Because obviously when you have chronic bronchitis, you're not going to run around, you're not going to exercise. So the patient is overweight. Okay. To compensate, the patient develops elevated hemoglobin. So your periphery, your tissues are not getting oxygenated. So your body starts producing more red blood cells. So the patient gets polycythemia. The patient develops peripheral edema. Why is there peripheral edema? So for that, you need to understand that when there is no oxygen going into the alveoli, the pulmonary artery that supplies the alveoli says there is no point in me supplying blood to this part. So it undergoes vasoconstriction. Okay, so that the blood can be redistributed to the parts of the airway that are better oxygenated. Okay, because there is vasoconstriction of the pulmonary arteries, there is pulmonary hypertension. When there is pulmonary hypertension, there will be right heart failure. Because of right heart failure, there is edema. Okay. Also, because of pulmonary hypertension, there is reduced left ventricular outflow. Okay. Because of reduced left ventricular outflow, your reticular RA system gets activated and causes salt and water retention in the kidney. So that also contributes to your peripheral edema. Why is there rhonchi and wheezing? Because there is obstruction, there is mucus plugging, there is fibrosis. So when air passes through that, there will be rhonchi and wheezing. Next slide. Press enter. Okay. So at the other end of the spectrum is your emphysema. So these are called as pink puffers. Why are they called pink puffers? So the patient, so these are their features. The patient has barrel chest. Why is it barrel chest? Because the lung is hyperinflated, because your air spaces are so much filled, you have enlargement of the air spaces, right? So there is hyperinflation of your lungs. So the patient is barrel chested. And the patient he has prolonged expiration. So because when we saw in the diagram, right, when the patient expires forcefully, your airway closes and it doesn't allow further air to go past it. So the patient tries to prolong his expiration and slow down his expiration so that some air can go out. And he breathes through pursed lips. He breathes through pursed lips to increase the pressure within the airway so that the airway remains open throughout expiration. And he sits forward in a hunched over position. He does this because he's trying to push out the air. So all your accessory muscles of respiration gets activated. So those like your intercostal muscles. So those will cause the person to bend forward during respiration. However, what happens is your blood gas values are relatively normal in these patients. Why? Because there is no problem in oxygen coming into the airway. There is only problem in the oxygen leaving the airway. So whatever happens, the patient manages to maintain oxygenation. And the patient has weight loss. Why is the weight loss? Due to increased effort. The patient puts in more effort to respire. Because of that, due to the increased work of respiration, as well as, if you remember the diagram, there was more TNF and more interleukin 1 and all being produced in emphysema. So all these causes cancer cachexia. So all of these cause cachexia, especially in cancer. So all of these causes weight loss, and the weight loss will be so severe that sometimes the patient will think, the doctor will think that the patient has some occult cancer somewhere. Next slide. Okay, so like I said, no one will be a pure pink puffer or a pure blue bloater. Most patients will be somewhere in between. Next slide. Okay, so like I said, the major site of increased airflow resistance will be your peripheral airway. And unlike what I said, I mean, nobody is purely emphysematous, nobody is purely chronic bronchitis. So partly the airway narrowing is due to inflammation, fibrosis, and mucus plugging, and partly it is by early airway closure due to reduced tissue elastic recoil. Next slide. Okay. So how do you treat a patient with chronic bronchitis? The most important thing is prevention. So you have to advocate smoking cessation, oxygen therapy, bronchodilators, antibiotics, because I told you both emphysema and chronic bronchitis can be complicated by infection. Physical therapy to get rid of the secretions, especially in chronic bronchitis. If the patient has bulla in emphysema, then bullectomy can be done. And in select patients, they do lung transplant and lung volume reduction surgery. Cause of death. So chronic, both chronic bronchitis and emphysema, they progress and the patient gets progressively worse, and frequently it ends up being fatal. And the cause of death usually, I told you that there can be pulmonary hypertension. So pulmonary hypertension can cause cor pulmonale, which is heart failure due to lung pathology, and the death can be due to heart failure. There can be acute respiratory failure, and if the patient is emphysematous, then I told you there can be subpleural blebs. So this subpleural blebs can rupture, and the patient can get pneumothorax and pass away. Next slide. Okay. So a brief line about pulmonary hypertension. So this was a study conducted over 6 years in 131 patients who had moderate to severe COPD. All patients were free from pulmonary hypertension at the start of the study, but 25% of them developed pulmonary hypertension at rest and 50% during exercise over the course of 6 years. So pulmonary hypertension and heart failure is an important cause of death in COPD. Next slide. So what causes pulmonary hypertension? Initially, the alveolar pressure rises so much that it compresses the alveolar capillaries, and then that causes pulmonary hypertension. Apart from that, I told you earlier that because there is not enough oxygenation to the airway, your pulmonary artery undergoes hypoxic vasoconstriction because there is no point in perfusing an airway that is not ventilated that much. Okay. Later on, there is remodeling of the pulmonary vasculature itself. So there is thickening and smooth muscle proliferation. All of this causes permanent narrowing of the pulmonary vasculature. Next slide. Thank you. Can anyone tell me who these people are? Hello? I think Sudarshan can tell me because he helped me out with the annotating.
I'm sorry, ma'am, I couldn't hear your question.
Can anyone tell me who these people are?
I'm sorry, ma'am. They look familiar, but I'm unable to correctly point. I think it's Robin, if I'm not wrong. I'm just taking a wild guess, ma'am.
Oh, you think it's Robbins? No, it's not Robbins. Okay, so you've heard of the Dolan Hill study?
No, ma'am.
Okay, so Dolan Hill study was a study that unequivocally proved that smoking causes lung cancer. So this is Dolan Hill. This is Doll. He is a doctor, and this is Hill. He is a statistician. So they got together and they came up with this study, and it was actually conducted on British doctors. So earlier, when smoking was so rampant, everyone used to smoke, especially doctors. Smoking was so rampant that, you know, in our CMEs and all, in all the conferences, doctors' conferences, they used to hand out cigarettes, and with medical subscriptions to medical journals, they used to get free cigarettes along with it. So that is how rampant smoking was. So they conducted a study on British doctors, and it proved that smoking is unequivocally related to lung cancer. So this is Doll and Hill. that famous study. That's it. Thank you.
Thank you, ma'am.
Any questions?
No, ma'am.
Okay, then I'll log out.